Weaning from ventilator is a gradual process of decreasing ventilator support. It is estimated that 40% of duration of mechanical ventilation is dedicated to process of weaning, and more so in case of difficult weaning. To discuss about weaning, I have with me Dr. Sameer Zog. Dr. Zog is consultant intensivist, Dinanath Mangeshkar Hospital and Research Center. Dr. Zog, welcome to podcast ICCM.
Thank you, brother. Thank you for the introduction.
So, Dr. Zog, what is actually difficult weaning and what are the common causes which leads to difficult weaning?
See, weaning is liberation from mechanical ventilation. So, when it was not standardized, just disconnecting ventilator and allowing the patient to breathe was successful almost in 50 to 60% of patients, maybe more than that, irrespective of the etiology of respiratory failure. But difficulty in weaning, that is simple breathing trial or spontaneous breathing trial. But the terms difficult weaning and prolonged weaning has got definite connotation in intensive care medicine. Difficult weaning by definition means somebody takes at least 3 attempts of spontaneous breathing trial or takes up to 7 days for weaning, that is difficult weaning. And prolonged weaning is the weaning process goes beyond 7 days. You are attempting weaning trial every day and still it is not successful for 7 days, then it is called prolonged weaning. So we'll be discussing mainly today about the difficult weaning in today's podcast. Right. And the second question which you asked, which is common causes of difficult weaning, the first and foremost we must remember what is the cause of respiratory failure for which we had ventilated this patient. The cause in broad terms can be classified into 3 broad categories. Is the pathology is of hypoxic respiratory failure? For example, are we ventilating the patient for pneumonia or ARDS or shock lung or left ventricular failure leading to cardiogenic pulmonary edema? This is one broad category of hypoxic respiratory failure. The second category would be obstructive airway disease, where hypercarbia or CO2 retention along with some muscle weakness will be the cause. And third cause of respiratory failure, which is often neuromuscular cause like intracerebral bleeding, large stroke, hepatic encephalopathy, traumatic brain injury, where primarily lung pathology is not there, but patient requires mechanical ventilation support to maintain his adequate gas exchange because there is a problem in either drive of inspiration or continuation of inspiration-expiration effort. So if we remember that why we have ventilated this patient, then the strategy will be according to the reason. The common causes of weaning failure, if the cause is hypoxia for respiratory failure, then probably your gas exchange or hypoxia is not improved well. Or there is another reason which has developed. For example, say patient has developed sepsis-induced myocarditis which has led to left ventricular failure. So common causes in hypoxic category would be your gas exchange is still not improved or your primary disease of pneumonia or ARDS still not resolved, and that's why there is a difficulty in weaning. You have to wait for some days. If your hypercarbia is the reason for mechanical ventilation, then probably bronchoconstriction is not reasonably controlled, or there is secondary infection, or the steroid dose might be underdosing. So the primary pathology is not adequately controlled or cured, which is causes. And third is persistent problem with neuromuscular issues. For example, the drive of inspiration is not adequate in case of large stroke or traumatic brain injury or grade 4 hepatic encephalopathy. Or there can be a neuromuscular reason where patient has developed critical illness neuromyopathy, which commonly we call as ICU-acquired weakness. This can be a cause of difficult weaning. So common causes, there can be plenty, but commonest causes in an Indian perspective would be unresolved pathology for which you are ventilating. Then issue of infection, which is Indian ICU, the infection is always our enemy number one. So new onset of infection, especially lung infection, and not to forget a new onset of either myocardial pathology or sepsis-induced cardiac dysfunction, and lastly neuromuscular causes. These are the commonest causes of weaning failure.
Thank you, Dr. Zog. I mean, very nicely explained about what exactly the difficult weaning is, and today our topic of discussion and causes. But just would like to know, how would we evaluate these patients? What would be the approach towards these patients when we decide, this is the difficult weaning? How do I approach towards these patients?
Once we, at least when I would label somebody as a difficult weaning, means consecutively 2 days I have given weaning trial. So first thing is I have to ensure that this patient meets my weaning criteria, which are standardized weaning criteria. For example, rapid shallow breathing index, PEEP requirement less than 6, FiO2 requirement less than 0.6, good inspiratory effort, good inspiratory trigger of sedation of neuromuscular paralysis. So this winnability has to be confirmed every day before you give weaning trial. So that's not today's discussion part. We are talking about once you fulfill the criteria, your patient fulfills the criteria of weaning, you do take him on either pressure support ventilation or you give him a TP's trial, which are two standard method of giving spontaneous breathing trial. So if they fail, and if they fail consecutively for 2 days by giving trial, I would probably label this patient as a difficult weaning, and I would look for causes which I already mentioned, and the standardized approach which is suggested by many respiratory or mechanical ventilation experts is called ABCD approach, which is nothing but a simple acronym for A stands for airway and lung issues, where you check for appropriate endotracheal tube size or tracheostomic tube size, because small size tube sometimes create a problem for weaning. Then you look for lung compliance and you look for gas exchange. If your PF ratio is beyond 150, 160, then probably patient there is high chance of winnability. If your PF ratio is just around 100, 120, it is impossible that somebody might get wean. Your PCO2 has to be reasonably controlled and respiratory acidosis should not be too much a problem. So lung and lung pathology and your lung compliance. The lung compliance has to be reasonably improved, maybe above 40. So that is the time where you can consider the weaning. The B, ABCD approach, the B stands for brain and neuromuscular issues. So I would look for consciousness, residual effect of sedation, residual effect of neuromuscular paralysis. And if there is a prolonged mechanical ventilation, which we have experienced in severe COVID patients recently in last 2 years, that patient on mechanical ventilation for 10 days, 15 days, then these patients inevitably develop some kind of neuromuscular weakness, which we commonly group them as a critical illness neuromyopathy, or nowadays they're called as SU-acquired weakness. So we sometimes have to do electromechanical studies like NCV or EMG study has to be done for this patient. And if patient is not becoming awake, we may have to do CT scan or MRI of this patient also to see whether there is new brain insert is not there or not. So B stands for brain and neuromuscular pathology, looking for them. C stands for cardiac evaluation, of which the two important evaluations are important. For example, echocardiography, which is repeated echocardiographic evaluation, definitely helps for two reasons. One, because all these patients on mechanical ventilation are vulnerable to develop new myocardial ischemia because of stress, because of use of not inotrope, but vasopressors, because of infection. All of them predisposed to new myocardial ischemia. And second, critical illness or especially sepsis-induced myocardial suppression or myocarditis is often missed pathology, which we have to remember in this context. So echocardiography will definitely help you. And if we find new right ventricular dysfunction, which is disproportionate of his lung pathology, then we may have to go ahead with CT pulmonary angiography to detect subacute thrombosis or even embolism. So C part of evaluation is cardiac evaluation, and D for this acronym ABCD is diaphragmatic evaluation, which is now gaining quite popularity because since the use of ultrasound, many of us have come to know that diaphragm definitely undergoes a lot of changes under mechanical ventilation. So if the diaphragm is not working during mechanical ventilation, when we use sedation and neuromuscular paralysis, there is common dysfunction of diaphragm occurs, which is either not atrophy but dystrophy occurs, and diaphragm is not used, it will go under hibernation or go to atrophy. So there are studies to show that the thickness of diaphragm or its contractility reduces if prolonged mechanical ventilation is performed in a given patient. So diaphragmatic evaluation has now become a quite exciting topic in weaning, where a UHD is a good tool to assess diaphragm function. So simple ABCD approach is nothing but an acronym for look for lung and gas exchange, B for brain and neuromuscular issues, C for cardiac issues, especially echocardiography, and maybe required CT scanning of thorax, and D for diaphragm evaluation. So this is the standard ABCD approach, and then there can be numerous causes of difficult weaning. For example, hypophosphatemia, or there can be thyroid dysfunction, or for a surprise, you may diagnose a subclinical myasthenia, which has triggered now, and your acetylcholine receptor antibody or muscle antibody become positive. There can be rare causes, but don't go for rare causes first. First, go for standardized approach, for ABCD approach, which is more important. So people often go for diagnosing myasthenia or diagnosing hypophosphatemia or diagnosing rare causes of weaning failure, which are very rare in my experience. But you should go always first rule out the common causes of weaning failure.
Very well explained, sir. It was brilliant. We are coming to the end of part 1 and we'll continue the further discussion in part 2, where we'll get to know about bridging interventions and new insights when it comes to weaning. Thank you very much. Thanks for listening. See you again.